Hi, my name is Emily St. Clair, and I am in the Family Nurse Practitioner Program. I'm in my first clinical rotation up at the Little Clinic in Greeley, Colorado. So my patient today is initials ST, 47-year-old female who presents to the clinic saying with a chief complaint, I think I'm having an allergic reaction. She presents with symptoms consistent with an allergic reaction, and she reports the symptoms began about 24 hours ago after she began taking a new brand of vitamin B supplements. She reports the symptoms came on suddenly after ingesting the supplements with a rash over her upper extremities and posterior side. The rash has not changed in location since onset. She did stop taking the vitamin B supplements after symptoms began. She reports symptoms include itchiness, redness, irritation, swelling that are all located to the site of the rash over arms and back area. She denies any associated fever, eye redness, throat, mouth, tongue, lip, or face swelling, shortness of breath, difficulty breathing. She denies history of anaphylactic reaction, and she also denies exposure to any new chemicals, irritants, photosensitivity, or unfamiliar environments, including recent travel. She's taken Benadryl 25 milligrams every 6 to 8 hours with minimal relief of symptoms. Aggravating factors include warm temperatures and tight-fitting clothing. She did have a similar reaction about 2 years ago after starting a new laundry detergent, and she is concerned about her symptoms because she has a big presentation to present tomorrow at the school board, so she's stressed. Her past medical history is hypothyroidism and estrogen deficiency. Pertinent social history includes she denies drug and tobacco use, no known drug allergies. Medications include Permeron 0.625 milligrams for estrogen deficiency and Synthroid 137 milligrams or micrograms for hypothyroidism. And she denies any significant stress or issues in a home, family, or personal relationships. Review of symptoms, she denies signs and symptoms of an infection, reports red raised rash over her upper extremities and back, appearance of hive-like rash, no bigger than the size of a quarter, skin is clean, dry, and intact, and she reports minimal swelling to areas of rash and irritation. She denies mouth throat pain, denies neck or throat swelling or narrowing, shortness of breath, chest pain. Vascular, she denies swelling, cold or warm extremities, numbness, tingling, or edema. So general or objective information or general survey. She's pleasant, well-kept Caucasian female. She appears in calm disposition. She's neatly dressed and groomed. Vital signs are within normal limits. We did a focused exam on her skin, clean, dry, and intact. The areas red, raised, rash and irritation scattered over bilateral upper extremities and posterior back. The rash appears light red, slightly raised hives, about approximately dime-sized, circular in shape, no edema to tongue, face, or neck, no significant lesions, ulcers, blistering, discharge, or drainage from rash. Her mouth and throat, uvula of those midline, throat pink, moist, without infections or swelling, tongue pink, moist, without swelling, respiratory unlabored, symmetrical lung expansions, breath sounds were clear to auscultation and bilaterally equal throughout. So the assessment, ST is a 47-year-old female who presents to the clinic with signs and symptoms consistent with an allergic reaction, most likely followed by the ingestion of a new brand of vitamin B supplements. She's got a history of hypothyroidism and estrogen deficiency that is followed by her PCP. So problem list, allergic reaction, and then her history of hypothyroidism and estrogen deficiency. Differential diagnosis for the allergic reaction includes anaphylactic reaction, contact dermatitis, and eczema. Our plan for her allergic reaction with the presence of urticaria includes a diagnosis, physical exam, and history. We're going to start prednisone 20 milligram tablets, 1 tablet orally, once a day for 7 days for allergic reaction. Also start hydroxyzine 25 milligram capsules. Take 1 capsule orally 4 days or 4 times a day as needed for 5 days. And then patient education includes monitor fluid intake and obtain adequate fluids, monitor for swelling of tongue, face, or shortness of breath, veno baths with warm water at least once a day while the itchiness persists, follow up within 10 days for worsening symptoms, or follow up immediately with a physician or go to the ER for breathing difficulties. Do not restart brand of vitamin B that is suspected to have caused the reaction. And then we just put a note in that she refused any topical cream and she preferred to use over-the-counter Benadryl or cortisone cream. And then for her hypothyroidism and estrogen deficiency, we told her to continue to see her PCP for symptoms or change to medication regimens. For my self-reflection, I felt that my nursing background helped me to look at this patient in a holistic manner. Through listening and questioning, I was able to figure out that she was really stressed out about her symptoms because of her big school board meeting that she had the next day. So I was able to take that into consideration. My weakness in this was probably my lack of knowledge in the treatment. We were able to calm her down once we were able to discuss the treatment so that she would feel better about her presentation the next day. My evidence-based article is a comprehensive literature review of all evidence-based research regarding types and subtypes of urticaria, including allergic reaction. The guideline was compiled using evidence-based research from Medline, Embase, and manual searches of abstracts at international allergy congresses between 2004 and 2012. So this article's reliable sound level of evidence, as all research was reviewed using the methodology checklist 2 and grades approach for randomized controlled trials, and the level of evidence is included in each guideline recommendation. So they recommend that acute urticaria plan of treatment should be aimed at controlling symptoms. In doing so, the attempt should be to reduce the effect of mast cell mediators such as histamine, PAF, and other target organs. So their first recommendation is to treat symptoms with second-generation H1 antihistamines. That's always preferred over first-generation H1 antihistamines with a strong level of evidence. On successful symptom relief, they recommend fourfold dose increase of modern second-generation H1 antihistamines. And finally, if symptoms are not controlled, they give two recommendations. First, an add-on trial of cyclosporin A or montelukast, or a short course of oral corticosteroids with a maximum up to 10 days. So in conclusion, based upon those guidelines, I would have altered our plan of treatment. We went directly to the oral steroids, and we also prescribed hydroxyzine, which is a first-generation antihistamine. So I would have likely tried a second-generation antihistamine. If that didn't work, increase the dose by fourfold. And then lastly, I would have prescribed the prednisone. However, I suspect the provider prescribed prednisone due to the patient's stress of having to present the following day. However, this plan is considered third-line treatment according to the evidence. So in the future, I will likely start with a first and second line treatment suggestions for my practice. Thank you very much for listening. Have a great day.